Okay, so good morning. My name is Maria Rubolino, and this is for the week 7-8 population health course. And my topic was on prevention strategies to prevent an influenza pandemic affecting population health. So just to give a brief background, not only on pandemics and influenza and things like that. So the first couple of slides will just be giving some background. So a pandemic is defined as some type of infection that becomes widespread across multiple countries during that similar time period. And what causes specifically the influenza pandemic is some kind of a new strain or new strain of that virus or a subtype that hasn't been identified or didn't get identified, earlier, and it becomes spread between humans, and it's a global spread. And then, unfortunately, humans have little or no immunity to this new virus once it changes or begins mutation, and then it becomes, spread very easily. So big data in healthcare, because this is population health, and those healthcare settings have large amounts of data. It's accumulated, collectively, and that's how do we get this big data in healthcare? From our electronic healthcare records, through sequencing of genomes, pharmaceutical records, healthcare payer records, wearable devices, medical devices. So that's how all this information gets accumulated to make that big data information. So unfortunately, healthcare data comes in many different formats, and so sometimes trying to get that format information disseminated may not be correct or accurate. So data becomes difficult to change that information, and improvements in technology have actually helped to convert that data. So it's becoming more useful, but of course, it's not perfect. So, monitoring big data to identify disease trends and health strategies, goes across demographics and geography, socioeconomics. So just now a review on, let me just move this picture myself. I'm going to move myself over here. Let me just go back. And this is just a review of influenza pandemics. And this is like the 1919 pandemic, so a long time ago. So this is that Spanish flu picture. So just giving you a historical review, almost 40 million people died in this 1918-19 Spanish flu. The first case was noted in Kansas, and it spread rapidly to Europe. Of course, we didn't know what was causing it. And it became deadly, and the Spanish flu was one of the most fatal among that 20 to 40-year-old population, and that's what we consider our most healthy population. So then we moved to the Asian flu, which is 57 to 58, and this started in China, and a microbiologist actually determined that this was, a different type of strain, and then that Spanish influenza, and that most people lacked this antibody. So just like I said, in those pandemics, approximately 2 million people died from the Asian flu, and it was a worldwide spread, about 70,000 deaths in the United States. And then we moved on to a Hong Kong flu in 1968 and 69. A new influenza A strain emerged in Asia, and the virus, spread to the United States, and almost 34,000 people died in the U.S., with this influenza. And then we move on to the Asian influenza in 1997, and this also came from Asia. It was infecting birds, but then of course it spread to humans, because remember, that's part of the pandemic. And then the poultry, of course, was dying too. So, but it didn't spread from human to human. So that was kind of interesting. And then in 2009, the H1N1, which we're probably the most familiar with, it was the most current influenza pandemic. It came from Mexico, and it spread rapidly to California and Texas. And the World Health Organization, provided insight into this, emerging threat that, could spread, which it did. And this seemed to have a greater effect on young children. You can say 87% of the deaths were in people age less than 65. So it affected really young children and then that adult population, but not specifically the elderly population. So it's kind of interesting how this one presented. And there were between 43 million and 86 million deaths in the United States between April 2009 and February 2010. So that is huge. So I don't think we realize like how these pandemics, I'm going to move my picture back over here now. So that 2009 pandemic that began in Mexico, you can see, and what I'm showing you here, because it was like a video map that was on the CDC or the World Health Organization website, you can see where it started, these little like dots, and then how quickly, in May, those deaths became, so it was really interesting to watch this little video, and, it's linked at the very end, so you can go to that website if you want to find that. There we go. So the future of pandemic of influenzas. In 2005, the World Health Organization created a newer pandemic guidelines that brought about pandemic preparedness, across all levels. And, this pandemic preparedness cannot be taken lightly. And we've had a lot of discussion board posts around this pandemic and how, our future ones, we need to be prepared. And the research is saying it's not if another pandemic of influenza will occur, it's just when. They just, don't know. So they are saying that the research saying is if the influenza pandemic occurred now, similar to that 1918 one that I talked about, it's estimated that almost 1.9 million Americans will die from this, and close to 10 million will be hospitalized, which, I can't imagine the devastating effects in the hospitals, healthcare money that would be allotted for this. So, it's really important that being prepared and trying to be preventative too. So I'm making sure that everybody's educated. So that's kind of where this focus of this presentation is, really on preparedness and prevention. So we know that those influenza strains mutate so quickly that the idea of just eradicating the influenza virus is just not an option. Like, it just won't happen. And this is the Global Influenza Surveillance Response System. They call it the GIRSIS system. And you can just see that, throughout the years, I thought when you really look down at the influenza statistics, and between 2018 and 2019, you can see the different strains and when they're peaking, and just very interesting information that really, looking at the World Health Organization websites and the CDC, it's really an eye-opening of, multitude, not just of influenza, but, whatever data they're carrying. So the seasonal influenza, like, let's say the one we had last year, leads to approximately 650,000 deaths every year. And this is why influenza vaccine, is important, because the CDC firmly believes that starting there is probably the most important thing. Preparedness is key, but starting with vaccination is really important. So, and who do we want to really focus on being vaccinated? Because you look at that historical data, so that elderly, the young children, pregnant women, and any individuals that have a weak or vulnerable immune system. So when we talk about, population health and, data sets, I linked in, the large data sets, through the CDC, the World Health Organization, and that's how I came to this topic. And of course, you're welcome to look up that information. And this is through the CDC, and it talks about disease burden, and just this is those big data numbers that they're gathering. And how do we reduce influenza transmission? Because that's really what, the key here. This is the CDC. This is one of their slogans, that take 3. And what do they say? These 3 steps by the CDC is getting the influenza vaccine. So everyone 6 months and older, unless, there's a medical contraindication to get it. They're saying during pregnancy, at any point during the pregnancy, you can get this influenza vaccine, and really focusing, on our elderly population. The second step, besides vaccine being number one, is taking preventative steps to stop the spread of germs, like avoiding close contact with individuals. If you're ill, stay home for at least 24 hours after your fever has subsided. Cover your mouth and nose when coughing or sneezing. Washing your hands with soap and water. I mean, that's really key. And then, of course, the alcohol-based gel sanitizer, is a second best if soap and water are not available, but always, relying on that soap and water. And then disinfecting objects and surfaces, countertops, and really, I mean, it comes down to, like, especially in those healthcare settings, it's the computers, screens and keyboards, pens and pencils, if there's pencils still used, and the counters, the phones, often healthcare workers have to carry like a central, phone system too in their pockets. So those should be cleaned. I mean, it's all these things that harbor bacteria, the doorknobs. So there's a lot of different things. And then if you get the flu, take the antiviral medication, and the goal is to start it within 2 days of becoming ill. So you can just look at this data. So you have current data versus the February 2019 influenza. So you can see that, currently there's, not really a flu going around, but you can see in 2019, these are the, the cases of the flu, and that's like through that weekly surveillance system through the CDC. Global interventions addressing potential of another influenza and a pandemic. And remember, I told you that it's going to happen. It's just when. So surveillance is key. So we have the CDC has ongoing surveillance, and I talked to you about that GISR system that in that previous slide, that was established in 1952 to monitor these big data information. So that surveillance system is still ongoing today, and the World Health Organization is collaborating through surveillance systems with other centers throughout the world. And there's actually there's a total of 144 of these type of centers throughout the world in 114 different countries. So, and those are the frontline agents to really watch for surveillance to making sure those diseases aren't spreading. And biannually, the World Health Organization actually convenes through the technical consultants, and they have meetings to make recognitions on the viruses, what viruses to be included on the next vaccine. And they're looking at all this collective data, which really, being in healthcare for this long, I had no idea all this was going on the back end of, how we find that vaccine, the right one. And then yet there's still misses, as we saw that, that last year or the 2 years ago that we had saying that they had to develop a new one to cover the current strain that was being disseminated. So the CDC and the World Health Organization are continually looking at potential pandemic influenzas viruses across the world. And this is where those global surveillance response system that I keep talking about, this is where they're located. So I think this is amazing information that I particularly didn't know about. And then how can a nurse leader intervene? So this is really, that nurse leader driven intervention. So how are we as a DNP prepared nurse going to affect this? And what my intervention was, what I chose, although, we have students doing different kind of things on just influenza. Mine was really, focusing on healthcare worker barriers, because constantly I'm seeing, when I go into the hospitals that nurses are wearing masks, but those masks are not even placed correctly when they're in patient care areas. And when you ask them, they say usually, why they didn't get the flu vaccine. I mean, I've heard things like, I've had a bad experience. I had it and I still got sick. I know somebody that has, some poor outcome with it. So, you kind of hear everything differently, but sometimes those same reasons are, I hear over and over. So addressing that healthcare worker barriers to the influenza vaccines, and especially if they've had negative experiences or they have personal beliefs, they don't believe in vaccines or religious beliefs, educating the importance of healthcare workers increasing our vaccination rates, and considering offering like an incentives to encourage annual influenza vaccines. So maybe those healthcare organizations can give them, a gift card, or give them, free lunch at the cafeteria for the week or something like that. So DNP nurse leaders should continually reinforce the importance of herd immunity, meaning that community immunity, when discussing the benefits of influenza vaccines. When I looked at the statistics, I was actually kind of shocked about, I know what happens in the hospitals that I visit, with my students. And I also know what happens in like the office setting where I work. Like, I don't see a lot of them getting vaccinated. So it's really interesting. But when I saw the statistics, in 2016, only 66% of healthcare workers reported receiving the influenza vaccine. And although these numbers have seemed to improve for the 2017-18 flu season, the healthcare worker vaccination rates was about 78.4%, which was an increase from the 66. But I mean, you can still see we have 20+% that are not being vaccinated, which is shocking to me. Influenza vaccination rates were highest among physicians, lower among nurse practitioners and physician assistants, and the lowest among healthcare workers such as nursing assistants and nursing aides, which that's down to 71%. And it was shocking too when I'm reading these statistics that nurse practitioners don't really have high rates. And the only thing I can think of when I thought about this, like an anecdotal thing, although I couldn't find any data to support it, was that I wonder if a lot of these NPs and PAs are working in small offices or private practice settings, and they're not affiliated with a hospital, so they're not like offering that influenza vaccine, in the cafeteria or, in the break room. And so they just it's not something they're getting done. DNP nurse leaders need to ensure that healthcare organizations provide influenza vaccines free of charge to their staff during convenient hours. So they need to have on the night shifts, the day shifts, the weekends, all that, holidays, everything, they need to have these little, stations set up so that individuals that were working can go down, especially those if you have nursing assistants on those units. And this includes like extended healthcare facilities, things like that. If DNP leaders spent time with healthcare workers on an individual basis, educating about their concerns, including, why they don't want to have it done, then they may improve their, vaccine, the individuals getting the influenza vaccine. The U.S. Department of Health and Human Services, along with the CDC, have focused their efforts on vaccinating healthcare workers. So current studies show that the influenza vaccine will only reduce infection rates by about 50 to 60%. And I'm sure that you've heard individuals not getting vaccines because they say, well, I still got the flu. And that, that absolutely may be true. And this can play a role in maybe why healthcare organizations have a lot of financial hardships, because if you have 50% of your staff going off because of illness, then, it's lost money for them. It's lost for the hospital. They may have to call in registry or traveling nurses. I mean, it's a snowballing effect financially. So I talked about, my intervention, is definitely increasing those rates of vaccination among healthcare workers, all healthcare workers. But, the key is how are we going to do that? So educating, so having the DNP leader organize a task force. These are individuals throughout the organization on all levels, from physicians on down to, nursing assistants, including, housekeeping, and everybody develop this task force so that, and they're educated correctly on the importance of vaccine, giving statistics, how addressing those barriers. So once that team is educated, having that task force be disseminated throughout the organization to start to, vaccinate to educate healthcare workers to hopefully improve vaccination rates. And so we can, speak with them one-on-one, addressing their concerns, that task force team. So it's not just one or two leaders, but it's actually their peers educating each other too. And the DNP leader could have posters displayed in the hallways, in the waiting rooms, in newsletters, They can have, send reminders through the email up to all those unvaccinated employees. There could be a whole campaign, but it's also that dissemination information. If those posters are in the waiting rooms and the hallways, then you're educating the patients and their family members. So through this ongoing education, the importance of fostering team building is also needed to increase trust. And a lot of times individuals will trust their peers more than management. Oh, I'm sorry. And then providing vaccine administration during convenient times, which I've already discussed. So how can a nurse leader improve influenza preparedness? Preparedness is what we kind of talked about, but that DNP leader needs to work with the community. I mean, that's really what it comes down to. So not only educating those healthcare workers that are employed, but you also have, working with having annual influenza vaccines, having annual meeting or more than annual meetings, overcoming challenges within the community and within the organization, dispelling myths, making sure we give sound information that's evidence-based, and to help ensure public trust. And then understanding, garnering a better understanding of influenza pandemic preparedness requires not only health leaders, but state, local, and community health leaders. So working with public health department, that's really important. And then we have global intervention. So we've already talked about how the World Health Organization has their surveillance system set up, and to strengthen preparedness, early detection, early response. The Flu Net is another system that reports any new influenza cases to the World Health Organization on a weekly basis. And the Fluid is an additional system that reviews epidemiology of the circulating viruses associated with influenza. So currently, the World Health Organization is developing a tracking tool that tracks pandemic influenza severity through an assessment tool. And then this is known as the PISA, the Pandemic Influenza Severity Assessment Tool. And that's that PISA would constantly compare the strains of the viruses that are continually emerging. So that is a better assessment tool that they're actually working on. So they're looking at transmission, global transmission. So action plan, so I talked about my intervention, and the action plan throughout the community and globally is, the DNP nurse leader, with working with the physicians, that task force team, the employees, the community leaders, and how are we going to look at this influenza preparedness? So it's not only vaccinating, but being prepared for the next pandemic. And then DNP leaders, have that advanced education. I mean, this is what we're getting to not only work within the organization, but to disseminate that information throughout the communities, work with their colleagues, and ongoing collaboration efforts. And the DNP leader can also work with town hall meetings to address barriers to influenzas, vaccines, and any negative experiences. And how will we evaluate this? So I have a couple of different things. So once we've promoted that and we've looked at that task force can actually establish, that team needs to be completed by the DNP leader. Once the influenza season has ended, that task force and the DNP leader can look at the rates of vaccination for that influenza season and compare it to the previous year when there was no task force really involved. And so that's a perfect way to look at it. And also that I feel like that DNP leader can also send out a post-evaluation survey after that flu season is ended and determine, did that ongoing, communication through emails and posters and face-to-face, did that truly make any difference? Ask the individuals, did that make a difference in them getting the flu vaccine? And see if it's cost effective. So is it worth it? And throughout the community, looking at those interventions and looking at, did we have increased vaccination rates in the community? Did we, the other thing would be providing face masks, in the hospitals and all these large organization centers, maybe that would be beneficial. Did, people think that was better? Did we have lower rates of influenza because of that? Making sure that hand hygiene is readily available. did these things happen through all the organizations? So not in, obviously we know it's available in hospitals, but in schools, in church settings, things like that. Educating the community about the importance of covering their cough and the importance of social distancing. So like when you're ill, stay home, that kind of thing. And then statistically, how will we statistically look at this? I talked to you about, like the pre and post. Those are descriptive statistics, mathematic modeling, and methodology for prediction of the future, and prediction algos, will qualitatively analyze the data. Utilizing these analysis, researchers from the CDC and the World Health Organization can look at big data, that's what they're doing, population size, how did it affect mortality rates, and then use of statistical analysis to follow a population within regions. And the purpose of this statistical analysis to provide estimates on how influenza has affected global health population. And since using those statistical analysis is useful in identifying impact of the disease burden. Preparedness through statistical analysis is increasing stockpiles of antiviral medications, better understanding of disease outbreaks, better understanding and evidence approaches to controlling the spread, and enhanced statistical modeling of varying strains. So algos can be used in a multitude of factors. And then cost and budget preparedness. So influenza is proven to be a huge economic burden to the world across all age groups. And in the United States, influenza costs have risen to like $87 billion annually. That's just in the United States. And then $15 billion in lost productivity alone in 1 year. So that's major. 65% of the total costs were related to hospitalizations and deaths associated with influenza. And then you can see here, this is, the burden, influenza burden by season. So you can see, look at this 2018, this is death, hospitalization. This is huge on, cost. And then again, so influenza vaccines, so it's not really the fact of cost about, because insurances pay for these vaccines as long as you go to an in-network provider. So they don't charge a copayment. Medicare Part B, they pay for the vaccines for individuals 65 and over. Most Medicaid agencies also covers this vaccine. And although the vaccine costs are minimal, $20 to $42, if you didn't have any insurance, you may not be able to afford even the $20. So, but we have free, often, there's free mobile clinics. So when we're doing these vaccines within the hospital for healthcare workers, wouldn't it be great to also, if there's family members or visiting people in the hospitals, providing them with the vaccines too. And budgeting for a pandemic, pandemics disrupt the economy, schools, work, hospital. There's so many facets of economics and related to influenza and a pandemic. So overall, a lack of vaccines of influenza among healthcare workers will sadly affect the number of sick days among healthcare workers. Influenza costs can rise in the United States to upwards of $60 to $80 million every year. And then budgeting for that preparedness is much cheaper than, which is about $4.5 million, what they say to the United States. Therefore, this exemplifies why preparedness is so important. And remember, preparedness starts with vaccine, administration. So the program impact on, enhanced education. So, there's still going to be healthcare workers and individuals that are still not going to be, want to take part in having a vaccine. But the CDC reports that healthcare workers are more likely to be vaccinated when the employer mandates it, although this has a lot of ethical issues and there's lawsuits brought about for, because of this. But that's what the CDC is reporting. And then when the influenza vaccines were not mandated by an employer, it's been reported that those organizations have the lowest vaccination rates, down to 47%. Physicians and pharmacists, we talked about, they are the highest rates of influenza vaccination. And then you see that nursing assistants kind of went down. The CDC continues to recommend that all healthcare professionals receive this annual influenza vaccine. And then peer, we had to collaborate in week 7, and through peer collaboration, one student agreed that organizing a task force, what my idea of the initiative would be an effective solution to increase those vaccination rates. But of course, we can't force an employee to get that vaccine, and they can still wear their mask, but often you will see them below their nose or their mouth, hanging off their chin when they're like at the nurse's station. So that's not effective. And then there's studies that also say that when they get wet, from wearing them for so long, that droplets will actually be able to penetrate through that mask. And then because of the wetness, the sides don't stay sealed, and then droplets can come out there. So wearing masks not really effective either, but we don't know what the third best thing is. So the same student also agreed that post-evaluation survey given to the employees, would be great to determine, did this task force and this way to disseminate the information, was that, more effective, or did it influence their decision making at all? And there was also agreement that all healthcare providers should be correctly educated, educated about the influenza. And then once they have that information, they should be educating their patients correctly about influenza vaccine and dispelling myths or beliefs that are incorrect. And then here's my references. 1, 2, 3 slides. Okay. And that's it. Thank you. Bye.